All right, good morning, everyone. We're going to get started in this session. The title of this session is Advancing the Multidisciplinary Management of HCC, and this activity is supported by an educational grant from Bristol Myers Squibb. My name is Riad Salem. This is Dr. Santiago Aparo from Miami Cancer Institute, Baptist Health. And here are the faculty disclosures. And just briefly, the learning objectives is to discuss the benefits and limitations of LRTs, local regional therapies, and systemic therapies in management of HCC, and looking at disease outcomes across all stages. So this continuum of care is something we'll discuss. Outline the scientific evidence supporting the use of immunotherapy in HCC, the mechanism of action, etc. Evaluate the efficacy and safety, tolerability, and indications of available and emerging systemic therapies in managing HCC. Integrate the latest evidence-based guidelines. I don't know if you guys have seen, but in Lancet, the newest sort of BCLC guidelines were just published about a month ago, individualizing patient HCC therapeutic decisions, and implementing multidisciplinary HCC management that facilitate this continuity of care over the course of disease and transition between LRTs, local regional therapy, and systemic therapy as appropriate. So I'm going to start and speak for about 15 minutes on local regional therapies in HCC, and Dr. Aparo will take over after that and talk about systemic therapies. We'd like to leave a good 10, 12 minutes for some questions. I think there's a lot of activity in HCC. I have some questions. I'm sure you have some questions, but we'd like to have this to be as interactive as possible. Okay, so let's get into the discussion of local regional therapies, and I think if you're going to be dealing in HCC, everybody needs to understand the BCLC staging system and the therapeutic strategy. And that's probably because the biggest strength is that it gives you an algorithm to try to substratify the HCCs into a way that allows you to imagine what the disease burden looks like, whether there's extrahepatic disease or vascular invasion, and then associates it down with the, quote, best first therapy. And I would say that the staging system itself is very well recognized, is very well accepted. It does a great job to give you an idea of what you are dealing with. I think the controversy or the fun discussion comes in when you talk about the therapeutic strategy, and these are the recommended ones based on, quote, the highest level of evidence. And so you see, you go from ablation to resection to transplantation, back to ablation again, but this brings in bridging therapies. You have chemoembolization. You've got sorafenib, but now many more other therapies that Santiago will talk about, and best supportive care. So let's briefly discuss ablation. And if you look at ablation, sort of the 5 studies that most people quote in HCC are these here. Hundreds of patients that are treated. Overall survival is reported. Very similar. Recognize that when you look at survival outcomes in HCC, you have to understand what the natural history of disease actually is. And so if you have sort of a small disease burden condition and the natural history of untreated disease is 3 years, you implement a therapy and their survival is 3 years. If you don't have a control arm, one of the questions is, how much did you diverge from the standard of care and the natural history of untreated disease? So these are the studies that talk about this. The other thing that we need to now recognize, given systemic therapies, are post-treatment progression issues. And there's a slide that I will show a little bit later on that I've been showing for 10 years that make things very complicated to look at overall survival. When you look at controlling and comparing surgery to ablation, there are a few studies. Some of them a couple of them show no difference. One of them shows a significant difference. There are some criticisms to that clinical trial, and we can talk about that during the Q&A in terms of selection criteria. But that's another narrative that people talk about in terms of the challenges, the difficulties, and the issues you need to recognize at tumor board. Should we resect? Should we ablate, et cetera? And that sort of segues into this relationship of ablation to surgery. That basically the smaller the disease burden, the higher the expected outcome you can have with ablation. And you have the same relationship with resection. The slope of that line, however, is different. It starts with a lower outcome but extends longer, because the idea here is A resectable patient that has a 10 centimeter right lobe lesion is clearly not ablatable, so he's got more disease burden, but potentially you can impart that benefit. So there is a relationship between resection and ablation, and Vincenzo Mazzaferro words this as a complementary therapy, not competitive therapies, and that spectrum is something you should really recognize. When you look at the types of ablation that exist, the format of delivery, here are sort of the theoretical advantages and disadvantages we have as we went from RFA to microwave, and then of course the cryo and the IREs. And so each of them has purported theoretical advantages and disadvantages. There's going to be a paper coming out soon comparing RFA and microwave in a randomized format. I think you'll be interested to see sort of what this manuscript shows. But these are sort of the advantages and disadvantages that you have from tumor location, tumor size, risk of bleeding and tract seeding, et cetera, that I think is very important to recognize that, again, continue to build on your lexicon and knowledge base when you are at tumor board. So when you think about image-guided ablation on the left-hand side of the BCLC schema, in BCLC-A, basically, you know that resection RFA are basically very effective for early disease. They are complementary. Ablation is the recommended treatment of choice for early HCC disease who are not surgical candidates. But unfortunately, there are higher rates of recurrence. And if you look at research, people are talking about widening and expanding the area of ablation, et cetera, because of the local recurrence rate. We do know from the data from UCLA that as lesions get larger than 2.5 or 3 centimeters, they develop microsatellites. Microsatellites that you may be not seeing on imaging, so you might have burnt the primary lesion, but unfortunately there are microsatellites, and that's why expanding that ablation zone is something that we should target. When you look at the embolotherapies now, let's extend and go to the BCLC-B situation. Let's review sort of the more important ones. Chemoembolization is, of course, the standard of care. The rationale is pretty clear. You deliver a drug. You slow down the flow. The endpoint is sort of tumor saturation, et cetera. It can be done in a segmental manner, although early on it was done on a lobar basis. And it is the only embolotherapy that has shown a survival advantage compared to best supportive care. This is based on work that was done in the late 90s, early 2000s, and published in 2002. And that's based on this clinical trial, another one from Hong Kong that was published actually in the same time frame, that if you compare TACE versus best supportive care, there is an improvement in overall survival, and no comment can be made about bland embolization. This is something that the Sloan Kettering group advocates, and they are correct. No comment can be made as to whether TAE, transarterial bland embolization, improves survival. Bland embolization, as I just mentioned, also has the same similar rationale, cuts off the blood supply. It is simple and reproducible. And you hear many times the discussion of reproducibility and standardization. And it is my opinion that there are only two ways to standardize a local regional arterial therapy. Either there's no embolization or you embolize to stasis. I think it's very hard to embolize to 3 heartbeats, 5 heartbeats, 7 heartbeats. I think that can be complicated. So either complete stasis or no stasis whatsoever is my opinion. But that is the rationale of bland embolization, and that's been their position for years. You embolize to stasis. So bland embolization. And this is the largest series that the Sloan Kettering group has published on when it comes to bland embolization. Karen Brown's group, 766 embolizations, over 300 patients. Good overall median survival, 21 months. A bit of a mixed bag of types of patients. They are done on an inpatient basis, and I know that at Sloan, at least they're doing these procedures under general anesthesia. So one of the issues here is that, well, if there's a therapy where that can be mitigated, does that make any sense? And this is the overall survival that I just mentioned, with a median of 21 months. Drug-eluting beads. Let's take the next iteration of embolotherapy. It is the dose that is standardized. You often hear that it is standardized therapy, and the dose is prescribed dose is certainly standardized. The injected dose is never really the same, and so that's something that we need to discuss. The endpoint of substasis is advocated. And the Precision 5 clinical trial was the first one to compare drug-eluting beads and conventional chemoembolization. 212 patients, randomized phase 2, did not meet its primary endpoint of better response rate at 6 months, but did show that there was a subgroup of patients that maybe did benefit from drug-eluting beads, those with worse performance status, worse liver function, and worse disease burden. Expand that now to the SPACE clinical trial, where this is another randomized phase 2, adding sorafenib to drug-eluting beads, primary endpoint time to progression. That is the correct endpoint in a randomized phase 2. The study was effectively or clinically negative. Small improvement in time to progression with a P of 0.072, but no difference in time to extrahepatic metastases, time to vascular invasion, et cetera. And so people are now, this was sort of one of the first studies that suggested, well, maybe there's no real benefit of adding sorafenib to drug-eluting bead TACE, and this has now been replicated in other studies. Small randomized phase 2 study here from the Sloan Kettering group looking at bland embolization versus drug-eluting bead, randomized, federally funded clinical trial, so very well conducted. Difficulty in enrollment, as any randomized study may have, and here's the consort diagram here. 50 patients, 51 and 50 patients in each arm, basically showing that the response rate when you compare bland embolization and drug-eluting bead is about the same. So unable to demonstrate the purported advantage of drug-eluting beads compared to bland embolization, with, again, overlapping survival curves and overlapping PFS curves. So their position is the drug-eluting beads, in fact, most likely when you do a clinical trial, do not demonstrate an advantage over bland embolization. And finally, the last one is the radioembolization. This is a non-embolic, microembolic therapy, which in my opinion is very reproducible because of the lack of embolization. There's no endpoint of stasis. Several concepts emerge from Y90. One of them is the radiation segmentectomy, the ability to deliver a very high dose selectively in a small area that is not ablatable. So deliver an ablatable dose. You hear that from radiation oncology all the time. You can do that with Y90. And you can show that if you administer 190 or 200 gray, you can get CPN, complete pathologic necrosis. Expand that concept now to radiation lobectomy. The idea now, and an improvement in HCC narrative, that there are patients with HCC that would ideally be resected for it not for a small future liver remnant. And while we heard a lot of discussion yesterday about PVE in the HCC session, I guarantee you very few of them are doing any PVE for HCC because of the belief that fibrotic cirrhotic livers don't really hypertrophy. And in fact, that's been demonstrated. And so the more cirrhotic it is, PVE is not going to work all that well. And so maybe there's a different tool to consider, and that's what Y90 performs. We performed a small randomized phase 2 clinical trial, the premier clinical trial published in Gastro last year, looking at randomizing conventional chemoembolization to Y90. Here's our consort diagram, a small sample size, only 45 patients, because we had tremendous difficulty in enrolling in this clinical trial. Maybe they were all going to the clinical trials that Dr. Aparo will be talking about a little bit later on, but very difficult to randomize these two therapies, but nevertheless we did. And we found a very different time to progression comparing Y90 to chemoembolization. The chemoembolization group had a TTP of 7 months, which is right where the published literature is, and our median in the Y90 arm was not met after 26 months. So the median was not met, with no difference in overall survival, bringing up the discussion as to whether TTP can be used as a surrogate of survival. Now, I've been showing this slide for about 10 years, showing the difficulties of performing clinical trials in early HCC or intermediate HCC. And that's because a patient that has HCC, once they progress, they get rediscussed at tumor board and go on to a different or possibly the same therapy. Once they progress a second time, they get discussed yet again, and now you have a different combination. And now they progress a third time, and here you are, and now you have regorafenib and nivolumab. So there's almost no way, and this is a discussion I want to have with Dr. Aparo, there's almost no way to perform a survival clinical trial in early and intermediate HCC to try to compete with these agents, because these agents are just focusing on the advanced side. But this is the real-life situation of what happens to patients. The post-progression issue is a real issue, and so we can talk about that during the Q&A. And finally, after 15 years, at least for us, we have decided that Y90 is now our institutional standard of care when it comes to the transarterial therapy, rather than at every tumor board, at every case, ask whether you're going to do bland embo or DEBS or conventional TACE. We've decided that Y90 meets most of those criteria after a 15-year, 1,000-patient experience, and it's really summarized by this survival table, right? We can talk about technique and response, but at the end of the day, people want survival, and we saw some very prominent survivals here, stratified by TNM, UNOS TNM, and by BCLC. So this was the genesis of our affirmation for Y90. So to summarize, and to leave some time for questions after the session, the local regional therapies, there are some technical variabilities that people need to recognize. There are many imaging challenges that people talk about. So, there are some comparative studies that are lacking. More and more are coming on board, but now with the ever-increasing complexity of HCC and the systemic agents, it's going to be very, very difficult, but we can talk about that. And of course, as interventional radiologists, you need to recognize your ablative and your embolic therapies. Thank you for your attention. I'd now like to invite Dr. Aparo to the podium, who will be discussing systemic therapies in HCC.
Good morning. Thank you very much for the organizers for inviting me for this presentation. These are my disclosures. So I always go back to the BCLC criteria. I know you've seen this slide a million times in almost all the presentations that for hepatocellular carcinoma, and I'm going to focus on intermediate and advanced stage BCLC B and C. And the reason why I go back to this slide, because I think for oncologists and interventional radiologists, it's very clear what to do with patients with advanced stage C. But a lot of the trials that I'm going to show you, you will see that the inclusion criteria using systemic therapy also included patients with BCLC B stage, which again, based on these guidelines, embolic procedures are recommended. So I think it's very important to understand that this is a gray zone, and it's always important to discuss these cases in an interdisciplinary meeting in tumor boards and decide if the patients really will benefit from local regional therapy before we jumped on offering systemic treatments. So if I had to give you this presentation last year, it will take me probably 30 seconds, because we really, over the last 10 years, we only had one drug approved for hepatocellular carcinoma. As you all remember, in 2007, the SHARP trial was presented, and it was sorafenib was the first drug that showed a survival advantage in advanced HCC. In the last year, we have new drugs that were presented. Again, not all these drugs are FDA approved. We have positive trials with 3 biologic agents, tyrosine kinase inhibitor, regorafenib in second line, which is FDA approved, lenvatinib and cabozantinib in first and second line, and 1 immunologic agent, an immune checkpoint inhibitor, nivolumab, which is also FDA approved for second line treatment. And I will give you a review of all these trials that were presented, but I want to focus mainly on the FDA approved drugs. As I said before, we're going to talk about this, where all phase 3 trials, with the exception of the Checkmate 040, which was a phase 1 trial using nivolumab. I will also give you just one slide on the future trials and what could be future directions for advanced hepatocellular carcinoma. So going to the first trial, the RESORCE Trial was published early in 2017 by the Barcelona group. It was a randomized phase 3 study comparing regorafenib with placebo in advanced hepatocellular carcinoma that had progressed on sorafenib. Patients had to have a good liver function, Child-Pugh A, and the primary endpoint was overall survival. This is the study schema. Patients had advanced disease, good performance status. This was a multi-center trial, and it randomized patients 2-to-1 to standard doses of regorafenib, 160 milligrams once daily, 3 weeks on, 1 week off, compared to placebo. And patients were treated until toxicity was unacceptable or until they progressed. In terms of patient characteristics, these were really, the majority of the patients were BCLC BCLC. As we can see on the right side of the slide, over 80 to 90% of the patients were BCLC-C, so and 80% of the patients had macrovascular invasion. So really, these were patients previously treated with fairly advanced hepatocellular carcinoma. These are the results. The primary endpoint was overall survival, and it was reached by the study. The median overall survival for this patient was 10.6 months, and the difference with placebo was highly statistically significant. The secondary endpoint, which was progression-free survival by modified RESORCE criteria, was also met. So in terms of the responses, again, regorafenib is a tyrosine kinase inhibitor. As we usually see with these kind of drugs, we don't see great response rates. In this trial was about 10%, but a significant number of patients, over 50%, they had stable disease. In terms of toxicity, the main toxicity is what is expected for these drugs, which is hand-foot syndrome, diarrhea, fatigue, and hypertension. I want to mention that the rate of hand-foot syndrome is over 50%, so this could be a challenge for patients. If we go back to the SHARP trial, the initial class drug in this category, the rate of hand-foot syndrome was about 20%, so this is more than double. So this could be a limitation when for patients, and sometimes in the clinical area could be a reason to stop or discontinue temporarily the medication. So what are the conclusions for this study? Regorafenib significantly improves the overall survivals over placebo for patients who have progressed on sorafenib. I think the safety was acceptable, with the main toxicity again being hand-foot syndrome, 53% of patients. And based on these results, the FDA approved this drug in April of 2007, and it's now available in the clinics. Changing gears a little bit, the second drug that is had been approved recently, it's an immunological agent. So I have a couple of slides about the concept of how these drugs work. Again, I'm not an immuno-oncologist, but I give you the basics. We do have two types of immune responses. One that is an innate immune response, is the first mechanism of defense of our immune system, and the main effectors are the natural killer cells. But most of these therapies, they basically modify or immunomodulate our adaptive immune response, which is antigen specific, and it produces a durable response over time with immunological memory. And the main effectors are cytotoxic T cells when it comes to anti-tumor effect. So in hepatocellular carcinoma, like in other cancers, there's an immunosuppressive state generated by the tumor and the tumor microenvironment that basically it's very well described in hepatocellular carcinoma. I'm not going to go into each of these mechanisms, but there's many mechanisms very well described that we know that in hepatocellular carcinoma there's an immunosuppressive state that if we modify, that's where the concept of these drugs apply, we can produce anti-tumor responses. So there's multiple drugs that are under investigation. Some of these are approved. I'm going to talk about nivolumab, but basically we have stimulating agents which stimulate the immunological system to be more active, or blocking agents. So basically the blocking agents are the ones that are most studied, and basically they block inhibiting signals. For example, nivolumab, it's a monoclonal antibody that binds to PD-1, interfering with the interaction between PD-1 and PD-L1, and that releases an inhibitory signal that lets the immune system becomes more active against the tumors. So with that introduction, this is the study Checkmate 040, which was a phase 1/2 dose escalation and expansion cohort trial testing nivolumab in patients with advanced hepatocellular carcinoma. These were patients with a Child-Pugh 7, meaning good liver function, good performance status. Patients with hepatitis B were allowed to be on the study, and it's always the concern with these therapies that we can have viral reactivation, but as long as the patients were on antiviral therapy, they were allowed on the study. And this was a slightly different population than the RESORCE trial, in terms that patients progressed on sorafenib, refused, or were intolerant. The study schema, it's a classical schema for a phase 1-2 study. They have a dose expansion cohort with 3 milligrams per kilogram. And basically, the primary endpoint was safety and tolerability in the escalation part and objective response rates on the expansion cohort. And patients were followed with imaging, CT or MRI every 6 weeks. In terms of the patient population, even though the patients were not everybody had to be progressors on sorafenib, the majority of the patients, approximately 70 to 80% of the patients, received prior systemic therapy. These are the results, the responses. It's 20% objective response rates, and what is interesting is the overall survival. At 6 months, 83% of the patients were alive, and at 9 months, 74, which I think these are impressive numbers. And in terms of the toxicity, as you can see, these numbers are a little lower, but these drugs, there's sometimes a misconception that these drugs do not produce side effects, but they can produce toxicity, asthenia, nausea, diarrhea, skin rash, transaminitis, and sometimes they can produce autoimmune type of side effects. The responses in this trial based on hepatitis B or C, or if they were exposed to sorafenib or not, on the escalation cohort, basically all patients responded. Patients that were treated with sorafenib or were sorafenib naive, and both patients with hepatitis B and C. So what about responses based on PD-L1 expression in tumor cells? PD-L1 expression has been, in the immunotherapy world, some sort of a marker to try to identify patients that will respond better, but this does not apply to nivolumab. As we can see from these graphs, patients responded independently of the expression of PD-L1 being less than 1% or more than 1%. This applies more to other immunological drugs, the other agents. So what is the conclusions of this study? Nivolumab safety profile was manageable and consistent across the cohort and demonstrated objective response rates and long-term survival in both sorafenib experienced and naive patients with advanced ACC. And based on this result, this drug was FDA approved based on accelerated approval in September of 2017. So I also want to share 2 other studies that were recently presented about 2 new drugs, which again are not FDA approved yet, maybe in the future, but I think they are positive studies, and I think it's interesting to present these results also. So the first one is a phase 3 trial of lenvatinib, another tyrosine kinase inhibitor, versus sorafenib in first-line treatment of patients with unresectable hepatocellular carcinoma. This was a global randomized open-label phase 3 non-inferiority study. So basically the study looked at lenvatinib to see it was comparable in terms of efficacy to sorafenib, and included patients with advanced HCC with good liver function, Child-Pugh. But again, as I said on the first slide, this study included patients with BCLC stage B or C, and they had to have adequate organ function, and they excluded patients that have portal vein invasion at the main portal vein. So as we can see on the prior 2 studies, a good number of patients, they have portal vein thrombosis invasion. So they stratify 1-to-1 into either lenvatinib or sorafenib at standard doses, and they look at overall survival as the primary endpoint. These are the studies. The curves do not separate. Again, we don't expect the curves to separate. This is a non-inferiority study. The overall survival in the lenvatinib group was 13.6 months. So it reached the primary endpoint. So what are the most frequent side effects? Compared to sorafenib, again, these are two tyrosine kinase inhibitors, but patients on lenvatinib, they have higher rates of hypertension versus sorafenib, we had higher rates of either GI toxicity or skin toxicity, like hand-foot syndrome. So what are the conclusions of the REFLECT study? Lenvatinib demonstrated non-inferiority versus sorafenib in patients with unresectable HCC. The safety of lenvatinib and sorafenib appear consistent with the previously reported, and based on these results, may be a potential treatment options for patients with advanced HCC. So this drug, lenvatinib, for this indication is currently under FDA drug application. So the last study I want to share with you, it was recently presented, I would say less than a month ago, by Dr. Abu Alfa from Sloan Kettering. It was a randomized phase 3 study of cabozantinib versus placebo in patients who have progressed on sorafenib. It was, again, a placebo-controlled study, and patients, again, like the RESORCE study, they had to progress on sorafenib, they had good liver function, and also the primary endpoint was overall survival. This is the study schema, very simple randomized phase 3. They randomized 2-to-1 to cabozantinib versus placebo, and the tumor assessment in this study was done every 8 weeks by RECIST 1.1. So these are the results. The study reached the primary endpoint. Cabozantinib showed a 10.2-month overall survival, and this was highly statistically significant compared to placebo. The most frequent grade 3 and 4 toxicities were, again, hand-foot syndrome, again, hypertension, and constitutional symptoms, like we see with this class of drugs. So what are the conclusions of this study? Cabozantinib significantly improved the overall survival versus placebo in patients with advanced HCC. The safety was acceptable, and based on these results, the company will likely file an FDA application this year. So what is the summary? It was very simple 1 year ago. We only had one drug. Now it becomes a little bit more complicated. In first line, we have one approved agent, which is still sorafenib, but we have this new drug, lenvatinib, which showed non-inferiority. They are both tyrosine kinase inhibitor. They were both, one was compared to placebo, and the other one, again, a non-inferiority study. And the toxicity is slightly different, as I mentioned before. Sorafenib, more skin toxicity, lenvatinib, more hypertension. So what happens in second line after patients progress or are intolerant to sorafenib? Here it becomes a little bit more complicated. We have now regorafenib approved and nivolumab approved. These are two different agents. One, it's a multi-target tyrosine kinase inhibitor, regorafenib, and nivolumab, an anti-PD-1, an immunological agent. So which one should we use? And this question came up in recent meetings. Should we use regorafenib, nivolumab? And the answer is we do not know. And I guess one thing that could potentially help us in the clinic decide between one agent or the other is the toxicity profile based on the clinical scenario in terms of which drug to choose. In terms of future trials, these are two trials that are currently ongoing. Checkmate 459, which is a phase 3. It will compare nivolumab versus sorafenib in frontline setting. This will be interesting to see. And the Keynote 240, which is a phase 3 study of pembrolizumab, another immunological agent, versus placebo in previously treated HCC. There was recently presented data at the recent GI ASCO about a phase 2 study using also pembrolizumab in patients with HCC with interesting results. But what I think it will be most interesting is the combinational studies, which again I didn't put here because there's multiple and there will be more, I think, which is a combination of immunological agents with local regional therapies. And yesterday, during the general sessions, there was a little bit of discussion about the abscopal effect, what it means, and I think it will be interesting to see how these agents interact when we use local regional therapies, but not just in the treated lesions, but in lesions who are far away, because the local regional therapies, as we know, can release antigens and basically can help these immunological agents to get a more effective, more intense immune response. Thank you very much, and I think we're going to have some time to have some discussion and if you want to ask some questions.
So we have about 10 minutes, a little bit more actually, to get some good discussions going. I think this is always the most fun of these sessions. So I've got a list of questions, but is there anybody in the audience that wants to start off with a really good one? There we go. All right, doctor.
I got it, guys.
All questions are good questions.
Could you speak a little bit about combination therapy? We mentioned about it. We now have some agents. Obviously, they hit at different points. So now we have a bunch of different medications that hit and trigger at different points. And then we have our local regional therapies. How do we see these going to, working together synergistically? Obviously, we're doing trials. Where do you think this is going to go? And, I think a lot of people will start using them. What's the right thing to do with that, Riad?
And Santiago, if I could add to that question, if you could pick one study design, which would be your favorite one? What agent, what drug, what local regional therapy?
Thank you for that question. I think it's very interesting. I think the concept and the paradigm on how we use, on what to expect from the local regional treatment and from these drugs is different. With tyrosine kinase inhibitor, when they were combined with local regional treatment, what we were trying to achieve is to improve the response rates. Basically on that lesion, can we use these drugs to make that tumor or that lesion more sensitive to a local regional treatment? Is it safe to do it? Should we use it before, after? I think with the immunological drugs, the concept is a little bit different because I think we want to see what happens in that lesion, but I think the most interesting question is what's going to happen outside. Can we do some sort of not ablative technique, but can we produce some necrosis? Can we release some antigens by these local regional treatments? How much is enough, and what is the best way to time it, to try to generate a stronger immune response? And this is being studied in multiple disease sites. In terms of your question, which is the agent that we should use and how, this is currently under investigation. We don't know. I would say, I think we're going to see more studies using the main two agents with nivolumab and pembrolizumab. But again, how do we time this? Should we do it before or after? It's a work in progress. I think there's some preliminary data, not just from HCC, but other disease sites, that we can do this safely, meaning that we can give these agents in the setting of either local regional treatments or radiation, and it can be done, but how the best way to time it, I think we'll see. I don't think we know that yet.
I have a question based on the discussion. So we didn't really talk very much about the SARA and the Cervinib trials, right? Those are clinical trials that randomize head-to-head Y90 to sorafenib. And these trials did not meet their endpoint. And so my question for you, Santiago, is when you have sort of a large sample clinical trial, 400, 500, comparing a device and a drug with all of the issues of crossover and the imperfection of comparing these two, how do you interpret a study like that? Is that a negative study, or is the negative study actually a positive interpretation? Are you a purist or are you a pragmatist?
I would say I'm a purist, being an oncologist. We want to see phase 3 data, and I'm going to quote Dr. Bruix on a recent GI meeting which I think he has to say that but I think it's very important. If you have a negative study, it's a negative study, and if it's negative, it cannot be positive. So I think when you interpret the study results, you have to go by the study results. But I think we shouldn't stay in a study result on the negative. We shouldn't focus on positive studies and forget about negative studies. I think that the question is more complex. Why the study is negative? What happened? Did we design the study correct? And I think the field is evolving, and we have multiple therapies coming in, and we have all these different techniques, and I think we have to go back to the data and see why it was negative, and see if it really, I don't think we should trash or we should say this therapy doesn't work, but keep asking the question and see if we need to do things differently.
So then let me expand on that, since I think people want to see some good discussion. So if you're a purist, tell us the rationale for the use of nivolumab after sorafenib based on a phase 1/2 study approved by the FDA. Is it the enthusiasm? Is it the response? Is it the field that is moving towards there? Again, if you're a purist, give us the rationale for Nivo, and can we convince you to adopt therapies that are local regional based on phase 2 data as well?
No, I agree, and I agree with what you're saying. The FDA sometimes gives accelerated approval based on response rates only without having a randomized phase 3. I don't think, the drug is approved. I don't think we're going to see ever a randomized phase 3. But I think we have to be, and I think in the clinic, beyond the study results, we have to, as I said before, which agents should we use? And I think it's very difficult. And I think, clinicians have to interpret these results with caution and not get too excited. I think the world of oncology is very excited, as it was described yesterday with the new immunological treatments. But again, these are drugs that work. Again, they're in general less toxic than prior agents we use. But again, these are not magical drugs. They have limitations. So I think we should be very cautious.
So then to expand, we have a group of in the audience. So we have mostly interventional radiologists, and most of the work that we have done has been based on imaging endpoints, response, and as you know, we have been for decades trying to advocate for response, and with probably mixed feedback from oncology, it's probably fair to say. But then enter nivolumab that has, quote, promising response rate, and then enter lenvatinib that has better response rate. So can you sort of make sense for us as to how we as interventional radiologists should interpret the field in oncology when it comes to response rate? Because now all of a sudden, response rate appears to matter.
Apparently, but I think, again, I don't want to speak for the FDA, but in terms of the data with nivolumab, again, even though the objective of the study was response rate, I think they guided the decision also in the 6 and 9 month overall survival for these patients. But I think it's, when it comes to more advanced HCC, basically BCLC stage 3, I think we need to focus on, I agree, on survival and not so much on response, because I don't think it matters, and I think that's been proven by the SHARP trial, and I think it's a proof of concept that not always response rates correlate with survival, and the drug that we've been using for 10 years is the opposite. The drug that was approved based on survival, the response rates didn't really matter.
There's a question, I think, in the audience. Go ahead, please.
Yeah, this is for Dr. Salem. Could you compare and contrast a little bit your resin beads versus polymer beads? Is 120 gray tumoricidal dose, would you expect the same response from one versus the other? And if you only had resin beads available in your institution, would you have come to the same conclusion as that being the first line of therapy for HCC?
Yeah, I think most of my positions when it comes to long-term outcomes are agnostic to device. I've written about that many times. The reality is I think the two generate different dosimetry models and doses to tumors. But one of the slides that I have lists all of the phase 2 studies when it comes to devices, and they all show very similar overall survival. So that's been my position for a long time. So I think for us in interventional radiology, and I'm interested in Santiago's position here, we want to move the BCLC-B area forward. I might interpret all of this activity in BCLC-C as in fact complicating the issue, not necessarily, I could take a bit of a contrarian position. It's fun to see all of these things, but what will you do if checkmate is 459 is negative? Now how will you interpret, nivolumab, and what will you do with it? But for me, I'd like to know, do you think it's possible to ever move away from BCLC-B chemoembolization as the gold standard? How would we ever move away from that with an OS endpoint, et cetera? How, in the environment with so many drugs and so many post-progression treatments, how can we design a trial that's actually doable? To me, my position is we appear to be paralyzed there, but I'm interested in your thoughts.
I agree with you, and I don't think I have a good answer for that question. I think it's all these agents coming in, and especially for patients with BCLC-B, and we have some of these studies, including some of these patients. And again, it's not very well specified. As I said on the first slide, I think it's very important, the interdisciplinary discussion, because not just by definition somebody that has multifocal hepatocellular carcinoma is a good idea to use these agents, even though you have phase 3 data and we have survival data. I think some of these patients, they still benefit from local regional treatment. So I think always an interdisciplinary discussion is key. The way I see it in the clinic, I would say when local regional therapy can be offered, I think we should try to leave these agents or systemic therapy for a later time.
So thank you for answering. Thank you for attending this session. It goes back to advancing the multidisciplinary management of HCC. Thank you for being here. Thank you to BMS for sponsoring this. Have a good day, and we can be here for a little bit longer to answer questions offline. Thank you.